This is Mohamed Sadek, and this is the second part of the cardiac arrhythmia treatment lecture series. So we had already discussed treatment of bradycardias, but we'll now be moving on to treatment of tachycardias. As mentioned priorly, we classify tachycardia into narrow complex QRS or a wide complex QRS tachycardia. And in the narrow complex tachycardia group, the tachycardia mechanism must be originating from the atrium. And the reason the QRS is narrow is because the tachycardia originates from the atrium, conducts down the his Purkinje system in a fast way, and then both ventricles depolarize simultaneously, yielding a narrow QRS. Wide complex tachycardias can originate from the ventricles, hence the QRS is wide because the complex is being depolarized through muscle, not through the his Purkinje system. Or they're originating from the atria, but there's aberrancy within the his Purkinje system. For example, a left bundle branch block or a right bundle branch block. So wide complex tachycardia could be originating from the ventricles, or they could be supraventricular tachycardias with aberrant conduction. Symptoms of tachycardias include fatigue, chest pain, palpitations, shortness of breath, syncope, or death. We'll first discuss the acute treatment of tachycardia. This is a slide from the ACLS guidelines. We always assess the patient's ABCs first: airway, breathing, and circulation. Make sure they're maintaining a patent airway, make sure that they're saturating well, place oxygen, and monitor the blood pressure and pulse oximetry. And then assess for signs of compromise. So, is the patient hypotension? Are they acutely ill? Do they have signs of shock? Are they in heart failure? And if the answer is yes, you want to get them out of the arrhythmia as soon as possible. Most of the time, this entails sedation with a cardioversion, so shocking the patient back into normal rhythm. However, if the tachycardia is narrow complex, meaning likely coming from the atrium, so supraventricular, you might want to consider giving adenosine instead of cardioverting. We'll discuss adenosine in the oncoming slide. If the patient is stable, then you have a chance to do a 12-lead ECG and reassess the rhythm. You also have a chance to get an IV access and attempt different medications or maneuvers prior to cardioversion. So if the QRS is wide, then the rhythm could be ventricular, and you might need antiarrhythmic effusion or consultation with a cardiologist. You may consider adenosine if you suspect that this is SVT with aberrancy. If the QRS is narrow, then it's SVT, and you might want to try adenosine or vagal maneuvers. So we've discussed about adenosine a few times, but mainly the main issue is suppressing the AV node. If the arrhythmia is supraventricular, so coming from the atriums, by suppressing the AV node, we may be able to better diagnose it or potentially terminate it. Specifically, if the arrhythmia involves the AV node, if we're able to suppress the AV node for a few seconds, we can stop the arrhythmia. In particular, AVNRT and AVRT will terminate when you suppress the AV node. Other arrhythmias, such as sinus tachycardia, atrial flutter, or atrial tachycardia, may not terminate with adenosine, but adenosine will allow you a window to diagnose the arrhythmia better or understand what it is. Here is an example of AVRT, atrioventricular reentrant tachycardia, terminating with adenosine or vagal maneuvers. So the arrhythmia terminates and you resume sinus rhythm. Here's an example where adenosine or vagal maneuvers blocks the AV node. As you can tell, the P waves are still tachycardic. They don't terminate, but this may give you a chance to diagnose what exactly is happening. Here's an example where a patient was having a narrow complex tachycardia and adenosine was given. And initially, it's hard to know exactly what's going on, but once you give adenosine, the sawtooth pattern in the atrium is quite apparent. So this is typical atrial flutter. And once you diagnose typical flutter, you can tailor your treatment according to atrial flutter and try to figure out what you want to do next. So depending on the tachycardia, it will respond to adenosine differently. Sinus tachycardia will slow down and block temporarily, but then it will resume as before because it does not rely on the AV node. The same thing goes with atrial tachycardia. There is a small subset of atrial tachycardias that do terminate with adenosine, but it's the minority. AVNRT and AVRT will terminate with adenosine. Atrial flutter will slow down and uncover the flutter waves, like we've seen in the example just before, but then it will resume. And atrial fibrillation will slow down and resume, but you'll see the wavy baseline. Wide complex tachycardia, VT will not be affected because it does not depend on the AV node. SVTs with aberrancy will respond depending on what they are from this list. Pre-excited tachycardia will terminate if the AV node is involved. For example, antidromic AVRT will terminate. But atrial flutter conducting down the accessory pathway may not terminate, of course, because it's coming down the accessory pathway and does not involve the AV node. And pacemaker-mediated tachycardias could terminate depending on the cause, but in these cases, magnet application is likely more useful. So how do you suppress the AV node? So we discussed adenosine a few times. You could give adenosine to suppress the AV node. You would need to make sure that it's given quickly and flushed quickly through a larger IV and a more proximal IV to the heart, because if it's given too slowly, you may not see the effect of adenosine. Other maneuvers, instead of giving adenosine, is to give a carotid sinus massage. Of course, you wouldn't want to do this with somebody with significant carotid disease. Trying a Valsalva maneuver, so trying to breathe out through a closed airway. For kids, facial ice packs have been described. However, this is quite difficult to do and is a last case resort. This is what a carotid sinus massage looks like. Basically, you stimulate the carotid at the bifurcation. This is at the level of the temple usually, and you have to press decently hard, and this will allow baroreceptors to give a vagal feedback to the heart and potentially stop the arrhythmia. So we discussed the acute treatment of arrhythmias, but then how do you prevent them from coming back? Well, the answer is either medications or procedures. So whether they're wide complex or narrow complex tachycardia, depending on what the cause is, if you're able to diagnose the cause, you can use medications or procedures to prevent them from coming back. One of the objectives is to outline the von Williams classification for antiarrhythmic agents. Class 1 agents interfere with the sodium channel. Class 2 are antisympathetic agents, so beta blockers. Class 3 affect the potassium channels, and class 4 affect the calcium channels, so calcium channel blockers. And class 5 agents work by other or unknown mechanisms. Here's exactly where the different classes of agents act. So depending on which channel the agent will affect, it will act on different phases of the action potential. Now there are many different medications in each class, but we only use 2 or 3 in clinical practice. And it's good to know a few agents from each class. So from class 1, usually the most used ones are flecainide and propafenone. And these are mainly used for atrial fibrillation management. Class 2 are beta blockers. Some of the most common beta blockers used is metoprolol. We also tend to use a lot of bisoprolol and carvedilol, depending on the indication. But you'll find that metoprolol is the most commonly used beta blocker. Class 3 agents, the most commonly used one is amiodarone. It's used for both ventricular tachycardias and atrial arrhythmias. For ventricular arrhythmias or atrial arrhythmias. Class 4 are calcium channel blockers, such as diltiazem. And class 5 has adenosine in it, and that's probably the most used medication in this class. And why do these agents work? Well, by blocking certain channels and altering the phases of the action potential, they change the refractory period or automaticity of the tissues. And by doing so, they may make re-entry or automaticity less likely to happen. So none of these drugs are perfect in stopping arrhythmias, but they reduce the probability of arrhythmias occurring by altering the refractory period or automaticities of cells at the cellular level. However, in addition to antiarrhythmics, we also have catheter ablation to help us treat some of these arrhythmias. And some of these arrhythmias respond really well to catheter ablation therapy. So we had discussed sinus tachycardia prior. So we don't usually treat sinus tachycardia. You want to address the underlying cause. By aggressively treating sinus tachycardia, the patient may decompensate. For example, if they're tachycardic from a pulmonary embolus, you don't want to slow them down because that's a mechanism to keep their blood pressure up and to keep them stable. And if you bring the heart rate down too fast, they may actually decompensate from the pulmonary embolus and not do well. So sinus tachycardia is usually because of an underlying condition. The body is compensating, and you want to address the underlying condition, not slow down the heart. Atrial tachycardia can be treated with medications or ablation. Junctional tachycardia could be treated with ablation or medications as well. AVNRT and AVRT could be treated medically, but most of the time we use catheter ablation as they are curable. Atrial flutter responds very well to ablation, and it's usually hard to treat medically because the heart rate is hard to control, and it's a quite simple procedure. So ablation is usually first line for atrial flutter. Atrial fibrillation is harder to ablate than atrial flutter, with success rates not as high, so we treat it with either medications or ablation. For wide complex tachycardia, ventricular tachycardia could be also treated with medications or ablation. We've discussed SVT treatment already above. Pre-excited tachycardias could be treated with ablation where we target the accessory pathway, and pacemaker-mediated tachycardia could be treated with pacemaker programming. So we had discussed re-entry before, and the main different re-entrant supraventricular tachycardias are AVNRT, AVRT, and atrial flutter. And this here is an example of atrial flutter where there is re-entry around the right atrium. And we discussed how re-entry occurs because there's more than one pathway to proceed within the conduction system. If there's two pathways, you can block down one pathway, go down the other, and then develop a re-entry circuit. So if you remove one of these pathways by ablation, if you burn one of the pathways, whether it be the flutter circuit, the accessory pathway, or the slow pathway for AVNRT, you can effectively prevent the arrhythmia from happening again. So if there's a short circuit, cut one of the limbs to lengthen it. And there are side effects from antiarrhythmic medications. So if an arrhythmia is easier to ablate, like AVNRT or AVRT or atrial flutter, we tend to proceed towards ablation earlier to avoid the side effects of chronic medication use. Ablation usually is undertaken from the right or left femoral veins. Catheters are advanced from the veins and at times from the arteries up into the heart. And we place multiple catheters inside the heart in order to assess the conduction system from within the heart. So usually we have an ECG from the outside to assess conduction from outside the body, but these electrodes give us the ECG signals from within the heart. Electrodes are placed in the high right atrium, in the coronary sinus, which gives us a window to the left atrium and left ventricle, into the right ventricular apex, that gives us a window to the right ventricle, and onto the AV node. And you get something that looks like this. So this is intracardiac signals. So this is an ECG performed from inside the heart. And it does look scary when you first look at it, But as you learn how to interpret these ECGs, which you don't need to in medical school, you understand how the arrhythmia propagates inside the heart. And for example, atrial flutter, but in order to stop it and prevent it from happening again, we perform a line of block with the ablation catheter to stop the re-entrant circuit. So usually the re-entrant circuit is in a counterclockwise direction around the right atrium. If we're able to form a line between the tricuspid valve and the inferior vena cava, called the cavo-tricuspid isthmus line, we can block the circuit from propagating anymore, and then flutter won't happen anymore. So we use the ablation catheter to burn a line of block so that the short circuit won't happen anymore. If there's an accessory pathway, likewise, we can target the pathway with ablation and burn the pathway. If an arrhythmia is occurring on the left side of the heart, you can make a transeptal puncture or cross through a PFO and access the left atrium. Ventricular arrhythmias are also amenable to catheter ablation. This is an example of a person who had an anterior myocardial infarction. As you can see, the anterior wall of the left ventricle is quite thinned and calcified, almost aneurysmal. And when we put catheters inside the heart, we measure the voltage inside the heart. Purple is normal, green and red is abnormal. And here we see that the basal voltage is normal, but in the apex of the left ventricle, there's abnormal voltage. There's a lot of scar. But within the scar, there are abnormal cells that depolarize very slowly, allowing for re-entry. And that's usually where ventricular tachycardia originates from. It originates from the scar because of re-entry, and then it conducts to the rest of the heart. And if we're able to target cells within the scar that cause re-entry, we can potentially stop the VT circuits. Sometimes the same patient can have multiple ventricular tachycardias originating from the same scar. But if we can place our catheters within the scar at the areas causing the ventricular tachycardia, we can terminate with ablation. Here's an example of a person with septal scar, and as you can see, each one of these red dots is an ablation point. So by ablating different parts of the scar that can cause the ventricular tachycardia, we can stop ventricular tachycardia from happening again. The problem is, ablation is not a perfect procedure for ventricular arrhythmias, with success rates ranging from 60 to 80%. But because ventricular arrhythmias are potentially lethal and can lead to sudden death, we need a more sure way to prevent patients from dying from ventricular arrhythmias. And even though the ventricular tachycardia might be initially stable, it can degenerate to ventricular fibrillation and lead to sudden death. If a person has a cardiac arrest in the hospital, we can get a defibrillator and shock them out of it. But the question is, how do we prevent people from dying suddenly when they're outside the hospital? And the answer is an implantable cardioverter defibrillator. So in patients who have ventricular tachycardia or ventricular fibrillation and survive the episode, or patients at high risk of ventricular tachycardia or ventricular fibrillation, such as those with very large infarcts, we can offer them to place them a defibrillator. So it looks like a pacemaker, but it's a larger box, and the lead looks like a pacemaker lead, but you'll see that these bright coils on the lead, these are shocking coils. And the defibrillator, if it detects a ventricular arrhythmias, will shock from the can to the coil, and this shock cardioverts the patient back to normal rhythm. Here's an example of a patient with a defibrillator, and these are EGMs, electrocardiograms, obtained from the defibrillator. And you see that the patient is in ventricular fibrillation, very fast ventricular rhythm. A shock is delivered, 41 joule shock is delivered, and the patient goes back to sinus rhythm. So this is an example where the defibrillator potentially saved the patient's life. And here the patient placed a tattoo just over the scar. There are other defibrillators that don't potentially go through the vein, So the one I showed before sits at the left upper chest and goes through the axillary vein and down into the heart. There are some defibrillators that actually also defibrillate, but from outside the heart. So this is a subcutaneous ICD that is placed under the skin in the axilla with an electrode that is tunneled under the skin and parallel to the sternum. So nothing actually goes into the vein or into the heart, but rather is all under the skin. So we have transvenous defibrillators and subcutaneous defibrillators. So that was the discussion of the treatment of tachyarrhythmias. The next portion will be discussing treatment of atrial fibrillation.